Welcome to the fertility and family planning session. Let's see, my name is Jen Chang. I'm a brain tumor survivor and also the science manager at the American Brain Tumor Association. Hold on, excuse me one second. Oh. Let's see. Are we on filming? Are we online? Okay, sorry. Okay, so welcome to the breakout session, Fertility and Family Planning. For many patients and their loved ones, the diagnosis and treatment of a brain and spine tumor can have a profound impact on their ability to have a family. Counseling and careful planning are essential in these circumstances. In this session, we'll discuss the challenges of family planning with a brain tumor diagnosis and resources to help. Our speaker today is Dr. Douglas Fair. Dr. Fair is a pediatric oncologist and associate professor at the University of Utah in Salt Lake City. He works at Primary Children's Hospital and the Huntsman Cancer Institute. He's a director of the University of Utah Oncofertility Program. He also serves as the director of adolescent and young adult cancer at Huntsman Cancer Institute. He serves as the director of the Childhood and AYA Cancer Survivorship Program at Primary Children's Hospital. And he also serves as the director of the Solid Tumor Program at Primary Children's Hospital. So please welcome Dr. Fair.
Thanks, Jen, and thank you for the ABTA for inviting me. It's really an honor to be in front of you, and for those of you online, welcome and thanks so much. And yes, I take care of solid tumors, which are tumors we generally say that are outside the brain or spine, but my other research and clinical interests of AYA, which I'll define for you, survivorship and oncofertility really kind of overlap a lot, and I think you'll see that. So I'm happy to answer any questions on those topics. I have no pertinent financial disclosures. These are the objectives in the agenda for today, is to recognize the importance in discussing the risk of infertility, the desires for building a family in the future, and fertility preservation options with a patient, identify AYA or adolescent and young adult, if you haven't heard that yet this conference this week, and put oncofertility in the context of the other challenges facing this age demographic, to identify the barriers, the discussion of infertility risk, infertility preservation options, to identify the strategies available to help with fertility preservation, to learn about the techniques and options for family planning after a diagnosis, and unfortunately we also have to understand and talk about the costs associated with these techniques and resources available to you, and to learn how to advocate for yourself or a loved one. So this is just a simple sort of diagram of an AYA with cancer, and I wanted just to put in context and give you some numbers. So generally in oncology we say pediatrics is either less than 15 or sometimes less than 18. AYA, adolescents to young adults, we say the NCI in this country, it's defined a little bit different in other countries, is 15 to 39. So fertility is a discussion for pediatric cancer, which we can talk about. But for the AYA population, it can extend a little bit into the 40s, of course. But for the AYA, fertility is a really big issue. And unfortunately, as many of you know, to achieve either a cure, remission, or just to stabilize disease, we often are talking about undergoing a lot of therapies that are gonadotoxic, and we'll talk about those. And the survival rate for pediatric AYA, it's individual, but in general in this population, it's north of 80% and really kind of north of 85% now. But one of the many late effects that we think about with chemotherapy and radiation and surgery is the risk for infertility. And just to, for our AYA CNS brain and spine tumor patients, as you've heard this week, you're not alone. There's about 10,000 new AYA brain and spine tumor patients per year in the United States. So this is the same diagram, but I put these red arrows to flag two time points to be thinking about fertility. So ideally, we're talking about it with your oncologist, with your fertility team before you start therapy. But that doesn't always happen for a myriad of reasons. Some, as oncologists, we are at fault for. But even if it's not discussed beforehand, I also want to really emphasize that fertility preservation is really important to think about and discuss and to bring up after you're all done with therapy, because there's often a lot of options still available to most. As I mentioned, I wanted to put oncofertility in the context of AYA issues because I think it's only fair. Being an AYA, I just recently transitioned out of this and became a 40-year-old, so now I'm an adult, I guess. But being an AYA, a young adult, I think we can all appreciate that this is really quite a liminal time in life where there's lots of changes. And being a cancer patient, we're really in between a lot of different things, between illness and death, wellness and living, AYA being a child and an adult, and survivorship, whether you have been cured, whether you're in a remission, whether you just have stable disease. All of these things, you're in between being a cancer patient and not a cancer patient. So that's just tricky in and of itself. And, this is one diagram to look at the different life disruptions of being an AYA. And I won't read through them all, but you can just see the myriad of things that we are going through and developing as a young adult. And fertility is one of those. So I wanted to mention, I'll talk about some resources throughout. One of the big groups in the United States, and really these guidelines are international now, but the National Comprehensive Cancer Network, the NCCN, I sit on the steering committee that helps write these guidelines and have helped write the guidelines that are patient-focused, and just know that that's one really great resource, and we have a special section in there thinking about fertility. Excuse me. So wanted to read these guideline statements to you, or at least the first one. And the reason I want to bring this up is because I have had the anecdotal experience where patients come and talk to me in survivorship clinic, or I'm doing a consult, and they feel intimidated. They were intimidated to ask their physician, their oncologist, their cancer team about fertility. And part of that is because I think people are sometimes just intimidated to ask their doctors questions, which I don't like, but that is an understandable fact. But also, patients don't know, is this a question I should be answering my cancer doctor, or is this something I just figure out on my own? So I wanted to really emphasize, it is on us as oncologists, as an oncology team, to bring this up. However, we don't, and we're going to talk about how to advocate for yourself if that didn't happen to you. But I just want to make it clear, this is our responsibility. The American Society for Clinical Oncology, they write guidelines for oncologists and oncology programs. They had this statement since 2006. All newly diagnosed cancer patients of childbearing age must be informed about potential loss of fertility and receive referrals to infertility specialists. So this is really on us. We're going to talk about, as oncologists, we're going to talk about what to do if you don't get that talk. And just re-emphasizing this about fertility preservation, it's one of the things that's just really hard and frankly sometimes frustrating to see that patients haven't had this conversation, because we have, not perfect, but we have some really great fertility preservation options, but they're only useful if you have access to them. And we're going to talk about the cost, but the first part of that is just having the conversation. And Dr. Niederhuber, the former director of the National Cancer Institute, wrote just about all of oncology care. Access to health care will be a greater barrier to success than scientific advances. So, it's exciting, it's sexy at times to talk about the new therapies, the clinical trials, and those are super important. But we also need to talk about getting patients what they need of the technologies and the medical advances that we already have. And we can walk and chew gum at the same time. And so we should be able to, your oncology team should be able to talk to you about your risk for infertility, fertility preservation options, and as a system, we need to get a little bit better at low or no cost fertility preservation options. And we'll talk about some resources. So the first question, I've kind of already been insinuating some of these answers, but do patients want to discuss fertility preservation? Yes, fertility preservation is a primary concern for survivors. About 75% of AYAs will say that fertility or infertility is one of the late effects that they care most about, and that goes along with just general AYAs, who the data say about 75% of young adults think that they may want to build a family later on. And maybe not surprisingly, that having a cancer diagnosis really can even place an increased value on parenthood because of the cancer diagnosis. And patients have often have reported that the loss of fertility can be as difficult to face as cancer itself. And not being able to bring this up and talk about this is a really big issue, because not just does it affect someone's future fertility, but there is research to say that AYAs, when they haven't been able to discuss their risk for infertility and plan for that, they find there's higher rates of they have lower self-worth. They don't rate themselves as a good of a dating partner. There's just a lot of things that go into not being able to control things such as fertility in the future. And then I definitely have already been emphasizing this, that our oncologists, our oncology teams, discussing fertility preservation enough. And no, really the most generous, I think, data would say that maybe about half of all AYAs across the country are having an adequate discussion about their risk for infertility and the fertility preservation options. And as brain tumor patients, I'll just say that the data is also clear, and I've also anecdotally I've seen this, that there's an increased bias of oncologists about talking about fertility preservation with brain tumor patients. And there's a myriad of reasons for that. Sometimes it's prognosis, sometimes it's symptomatology when they present. But all that is to say is there really just is no excuse for not bringing this up. It's just so important. And the data would also be clear that patients, regardless of whether they go through fertility preservation, like actually choose that for themselves, feel more confident in their oncology team and feel more confident about their future if they've just had the conversation, not necessarily gone through with fertility preservation. For those AYAs out there, I highly recommend this wonderful memoir. Is written by Suleika Jawad. It's called Between Two Kingdoms. And she was, I think, 23 when she was diagnosed with cancer, a type of leukemia. And she articulates and discusses the challenges of being an AYA with cancer so beautifully. She's such a talented writer. And there's a lot of great quotes in there, but I think one in terms of fertility is something I wanted to read to you, because she went to one of the top cancer centers in the country, and they did not discuss her risk for infertility with her at all. And she was going to go through a transplant and was going to be made infertile, and was made infertile. And she discovered on her own her risk for infertility and took actions on her own to do fertility preservation. And so this is what she writes on the lack of infertility discussion. She says, "As much as I appreciate the medical team support, the absence of communication on something so important felt like a breach of trust early on in our patient-doctor relationship. While my medical team was intent on saving my life, preserving my chance to be a mother someday hadn't seemed to be on their radar." So I was asked, also plug for UAAs out there, if you haven't heard of Elephants and Tea, if you haven't heard of them from the conference or otherwise, please consider looking into them. They're this periodical that is just beautifully done, and they come out with monthly installments, and they have themes, and they're very patient focused. So last year, maybe a year and a half ago, they asked me to contribute as a provider to a feature on cancer and fertility. So there's 6 incredible stories from patients who had cancer and AYA, and how they thought about their fertility, how they thought about their lack of communication or their lack of opportunities to do fertility preservation, depending on the story. So I think there's just a lot to garner from that issue. They asked me as a provider to talk about fertility preservation and why are a lot of patients, maybe more than half, as I mentioned, not having the conversation. And I wanted to highlight this not as a mea culpa for oncologists, but just to sort of understand why this issue of not having a conversation with your oncology team is tricky. So one, the awkwardness. You would think as physicians we would be comfortable talking about sex, ovaries, testes, but the truth is not always. Bad timing. Again, this kind of goes back to the bias where when you sit across from a patient who you were just diagnosed with cancer and you see how hard that is on them. We are humans too, and we don't want to further burden. And so sometimes there are biases such as, oh, I don't know if I want to talk about this, their prognosis isn't great, or they just look like they're overwhelmed right now. I can't burden them talking about something else. Or another bias that has been elucidated in the literature, unfortunately, is people making judgments on, whether a patient can afford that. And so I don't want to bring up something that they possibly can't afford. And those things are all totally unfair. A tough age, speaking for myself, I didn't really kind of think about fatherhood or having a family until I was like in my mid-30s. And so if I were diagnosed in my 20s, I don't know what thoughts I would have had about building a family, but I really wouldn't have spent a lot of time thinking about them. And then all of a sudden you're confronting a 20-year-old, a 25-year-old, a 30-year-old and saying, what do you want to do for family building later on? We're not trained on this. That's changing a little bit. We have a focus in our fellowship, and they have to go through mandatory oncofertility training, and that's somewhat happening throughout the country, but we're in general trained to treat cancer. And so I think this is a big one. As we'll get to, there are logistics and there are cost issues, and as oncologists and oncology team, when you're not comfortable with knowing how to navigate somebody, it often just doesn't get brought up. Okay, so now I'm going to talk a little bit about the science and the medicine of infertility. So when you're talking about any cancer patient, we can cause infertility by treating your cancer by injuring two areas, the brain or the gonads, so ovaries and testes, or in the brain. So there's two parts in the brain, this hypothalamus and pituitary. These are areas in the brain, if you haven't heard of them, that send messages through the bloodstream, through hormones, and they are the ones that talk to testicles or ovaries, tell them to start to turn on or start functioning around the time of puberty, but they're also throughout a lifetime are really sending messages. And so if you damage that control center, you also can damage fertility. And we cause infertility by, as we colloquially say, cut, poisoning, and burning, which is cutting, surgery, poisoning, chemotherapy, and burn. Now, as the aphorism goes, the dose makes the poison, meaning this is where really having a conversation with your oncologist as to how much radiation did my hypothalamus and pituitary get, how much chemotherapy did I get that could injure my ovaries or testes. So that's where that individual risk assessment of how likely I am to be infertile, along with a patient's age, especially for a female, considering that, becomes part of the nuanced discussion about whether they want to go through fertility preservation. All right, so I'm going to perform a cardinal sin in giving a talk, which is to say, ignore what's up on the slide. So why did I put the slide up there? I just wanted to show you, this is from a paper that came out that in 2020 that kind of talks about doing some risk assessments. And there's been maybe 5 or 6 very solid risk assessments papers that kind of help oncologists determine somebody's risk for infertility. So you do not have to pay much attention, but I wanted to show you, as you're squinting, just in general how we think about it. And the poison is in the dose, meaning that, first of all, there's different things here on the left. If you go down, looking at the different things that we often talk about as causing infertility. So alkylators, that's a big group of medicine. Being pre or post-pubescent also can affect that. Heavy metals, those are cisplatin, carboplatins. Transplant, which is just a lot of chemo overall, and then radiation exposure. So radiation to the ovary or testes, and also to the brain. But as you see, as we go across horizontally, or the x-axis, you can see there's the dose, and as the dose increases on chemotherapy or with radiation, you can see the increasing risk for infertility. And so we have female, male, and again, there's guidelines and charts like this that your oncologist and your oncology team can use to help guide decisions on risk for infertility. I wanted to, you can pay attention to this chart because I think it's really illustrative and really helpful. So this is looking at female infertility, and I think understanding this is really important, especially when you're talking about guidance for fertility preservation after therapy. So on the left here, on the y-axis on the left side, we have number of follicles. That's also known as like sort of baby or immature eggs. And then on the bottom, we have age, 10, 20, 30, 40. So there's 2 horizontal lines going across the dotted lines, and when the line that is sloping is in between those two, that is when we call it the reproductive window, or when a female could get pregnant. And as you can see, the blue arrow here, it's approximately age 12 or 13 when a female would start her menses or menstrual cycles. And then as you can see there, it's around in their 40s, around 40 when a woman might have more trouble getting pregnant. Okay, so I want to show the effect of what chemotherapy can do on this. So in this chart, I put the chemotherapy being delivered diagnosed at age 18. And it sort of does two things, as you can see with this line. So one, just injures and damages a lot of follicles. So you can see that sharp decrease in the line there. But also the slope of the line changes. And so what you see is in this reproductive window that should have been for most females somewhere between 14 or 15 years of age up into 40, 42, 39, depending on the individual. Now it's truncated and it's really short. But for some patients who might have already gone through, who have been diagnosed, who have already gone through treatment, they might still have room in their reproductive window to consider fertility preservation. And so again, I think the takeaways are, it depends on the dose, it depends on the therapy, and also for females, it depends on the age in which they are diagnosed. So it is different, this slope will look different if you are going through therapy at age 32 versus 22, 36 versus 27. So these are the different factors that a reproductive endocrinologist in infertility, REI, that is the term for a female infertility doctor, can help go through that with you. And just to demonstrate that, so if you take low-grade glioma, I'm just choosing that as an example, and I'm just choosing two different regimens that can be used for treating low-grade glioma. So there's one regimen called PVC, that's procarbazine, CCNU, and vincristine, and so that is very gonadotoxic, and so that would be an example of something that's high risk for infertility. Or you look at just single-agent temozolomide, in general, much less so. And just a word about biologic, immunologic, targeted agents, immunotherapy, because I get asked a lot about this. The problem is that I think there's two truths. The first is that in general we think that they are less gonadotoxic than standard cytotoxic therapy. The second truth is we're not totally sure. The outcomes, whenever we're looking at fertility research, unfortunately we're talking about something, the outcomes that we're studying, live births, are often years to decades for patients, and it's hard to kind of study that, so we have to use surrogates. And so that research is ongoing, and I'm part of a group that's trying to study nationwide outcomes for cancer patients and live births afterwards. But the truth is there's lots of new agents coming out, and they in general are less gonadotoxic, but there's not a ton of information really out there. I'm going to go through the fertility preservation strategies or options for females and males. So for females, if you're post-pubescent, meaning gone through puberty, three options. And the embryo cryopreservation is our medical term for freezing, oocyte or egg freezing, and then there's ovarian tissue cryopreservation. So the embryo and egg freezing, they are about neck and neck. It used to be about 10 or 15 years ago, we were not really great at freezing eggs and then thawing them as well as we were with embryos. So 15, 20 years ago, if your oncologist was talking about fertility preservation, they would sometimes talk to females about and here is a sperm donor book if you want to consider fertility preservation, because we were really poor at freezing and then thawing eggs. That's not the case anymore. So unless you're in a committed partnership, the general recommendation is to certainly freeze eggs. It takes about 3 weeks to go through this process. It's about 2 weeks of stimulating the ovaries with hormones, and then there's the extraction, or you use the term harvesting, or taking out the eggs and then putting them in the freezer. So that's the real big issue for some patients who present, who are very symptomatic, and their oncologist says, I don't think we have 3 weeks to wait. We need to start your treatment earlier. The ovarian tissue cryopreservation, this makes fertility preservation for prepubescents, because these two are not an option for young girls, but it's also an option for females who do not have those 3 weeks to wait. It is a procedure where it's a laparoscopic procedure where a surgeon will go in and take out an entire ovary or part of an ovary and store and thaw that. I'll talk a little bit more about that in just a little bit. One word of just the GnRH agonists, these are Lupron is a common medicine. There is some data in breast cancer patients that maybe it's protective of the ovaries against some chemotherapy. But if it is, it's a mild effect. And I just, again, anecdotally, and even the guidelines from the American Reproductive Society really try to highlight that it's not a fertility preservation strategy. There's no reason not to do it for a lot of patients and to consider it, but just don't consider it fertility preservation. Sometimes I've heard that from patients where they thought they were doing fertility preservation or that their ovaries were really going to be preserved or saved by doing Lupron. So just to, again, show you what this looks like on the female side, if you're doing egg freezing, egg cryopreservation, egg harvesting, we use all those terms. You can see that there's the needle there because unfortunately these medicines have to be, the hormones get broken down in the stomach, so you have to inject them. Seems extra cool, so you do that for about 2 weeks, and it's really stimulating the ovaries, as you can see on the bottom, and on the bottom, on the right, on the bottom, where there's the pink arrow, that is where, that is the patient who is getting these stimulatory hormones, where instead of getting one egg ready, it gets many eggs ready. And then below, on the bottom right, is an ultrasound showing those mature eggs. And so then those are the eggs that get extracted via needle, and this is a picture of that where there's an ultrasound probe, and this is usually in the vagina. Sometimes you could do it over the pelvis on the skin, and then there's a needle. The ultrasound is being used to locate those mature eggs, and the needle is used then to extract them, and then they are processed, and then they're put into a very special freezer and held there until usage later on. This is definitely a diagram you have to squint, and I apologize. I was trying to, on the right, that's an example of what we already talked about, which is the egg freezing process. On the left is that ovarian tissue cryopreservation. And this is different in that you have to remove the ovary or parts of the ovary. They put them into strips. And it sounds a little crazy, but how that's utilized later is those strips are then reimplanted when the patient wants to try to conceive. So surgery, they sew them back into the pelvis, and then the ovarian tissue kind of wakes back up, gets blood supply, and then the process of stimulating those ovaries, extracting eggs, and then ultimately collecting them, connecting them with sperm leads to, and then implantation leads to a live birth. And that we used to count. We now stop counting, but now we've had hundreds, if not over 1,000 live births done via the ovarian tissue cryopreservation strategy across the world. So, and it's no longer considered an experimental therapy, and it's one that if you're a female and you do not have the 3 weeks to wait before starting cancer therapy, should be discussed. Males. You'll see some inequities that we'll talk about between male and females based on physiology and cost. Because for males, for most, sperm banking is the most effective strategy, and it's also the cheapest and easiest. There are techniques for males who cannot ejaculate or get an erection. Sometimes there's tumors pressing on them, or sometimes they're too sick, and you can do something called a testicular tissue extraction. Okay. Now to the least fun part, which is the cost. And usually when I'm doing a consult and talking to a patient, I'll be going over whatever options their risk, talking about what fertility preservation options are available to them, and then I usually say, and here's my least favorite thing to talk about, which is the cost. But it's a reality in 2024. So these are some general costs of how much it often would be billed to a patient if they did not have any insurance, where you have egg cryopreservation, $10,000 or $15,000 for females, embryo cryopreservation, about the same thing for ovarian tissue. These are ballparks. And then as you can see in the bottom here, the sperm banking, and again, it's just hundreds of dollars. This is not including the cost of storage, which is generally about $450 per year, depending on what you're storing. So let me just sort of give an anecdotal picture of what this is like. A young adult is diagnosed with cancer, and hopefully they get they're told you might be at risk for infertility. If they are, hope they have that discussion with them. Then maybe the oncologist, or maybe they call a consultant, or maybe they have a navigator that comes and talks to the patient. They tell them this is the cost of this and that your insurance probably does not cover this. Some insurance does, and you should definitely check, and insurance is making moves on this, but in general, most insurance policies do not cover fertility preservation, even for cancer patients. It's really cruel. So an AYA, who's often not financially independent, is asked to write a check for $6,000, $10,000 right then. And they have to do that days or weeks after being told they have a cancer diagnosis. Most people do not have that money in the bank. In fact, a lot of fertility centers have connections with loan centers, and they say, yes, we have these other borrowers, the preferred borrowers. So it's really insane in this country that this is where we are, but that is where we are. So I'm going to go over some strategies a little bit later, but I'm going to put some plugs in here. We often can get the costs for females down by using Live Strong. There's Walgreens Heartbeat Program, Reunite Program. Those are ones that help decrease the cost of the medicines, because about half the money, $6,000, $8,000 is the cost for the hormones, the injections, and usually about $6,000, $8,000 are the costs for the ultrasounds and the procedure to extract the eggs. So there are a lot of different programs out there that can help defray the costs. So please look into whether your insurance covers it. Often doesn't. If not, look at these different programs. The Alliance for Fertility Preservation on this site right here, on this slide right here, the Alliance for Fertility Preservation down there, kind of in the middle. They're a group that helps increase insurance coverage across the country. I'm on their advisory council, but they have a list of all of the different programs that are available to help defray the costs, and some of them are unfortunately just if you have not had cancer therapy, but there's a lot that are for patients who are after they are done with cancer therapy and can help mitigate the costs. This is just a slide just to say how I think it's a really unfair problem that we have. And people can have different opinions on whether insurance should cover fertility preservation for the most common reason for fertility preservation, a couple struggling, or an individual wants to expand their reproductive window. And I have strong opinions on that, but I have very strong opinions about the idea that if you're diagnosed with cancer, you should not have to pay for fertility preservation. As an oncologist, if I injure your kidneys with chemotherapy, insurance doesn't say, sorry, we don't cover the kidney specialist. And they should have the same approach to the ovaries, the brain, the gonads. But we are making moves on that nationally and at the state level. And different insurers are, I think, coming around a little bit. But we passed 2 laws, and I helped co-author 2 laws in Utah. And again, the move nationally is in the right direction, but it's not moving fast enough for me. Okay, so what can patients do to advocate for themselves as we're wrapping up here? I think one of the things to talk about, particularly brain tumors, there is some mixed data as to, there's always a question of, well, I'm not in remission, I still have a tumor. If I get pregnant, the hormonal response, does that affect my risk of progression? This is where I'd say, really, I want you to go to an excellent cancer center. And if you don't hear what you want on your first opinion, I'd say really get a second opinion, because there's really different thoughts on the data there for some patients. So I really want you to think about that. But in general, for most patients, certainly, and maybe for all, we don't think that there's an increased risk of progression or change in survival by being pregnant. But please talk to an expert and see an oncofertility expert. We talked about this. What is my risk for infertility? What are my fertility preservation options? How much time do I have before I must start therapy? Again, there's a huge bias on oncologists, and they've had lots of studies where they've now shown with breast cancer and with brain tumor patients that there's no difference in outcome if you often wait 3 weeks. I know everyone feels a huge rush. I was just told I have cancer. I need to start therapy tomorrow. And that might be the case depending on your symptoms, but sometimes it's not. And as oncologists, we sometimes can be a little bit biased to telling people you need to start and you don't have 3 weeks to wait. And for females, it's just super important and just a difference maker. What can be done if there isn't time for fertility preservation? We talked about there's lots of these same options are available pre or post therapy, depending on what therapy you received and what your both your hypothalamus, pituitary, and ovaries or testicles are doing, and those can be evaluated with blood tests and ultrasounds. A fertility preservation expert mentioned that, and then who will be able to discuss the cost of the procedures and financial assistance programs. So the take-home points, as I've mentioned, there are barriers to getting a quality oncofertility consult, and I did this not just to rag on the oncology profession or to be a downer about it. I just want to make AYAs not feel guilty about having either not brought it up or not brought it up in strong enough terms where they felt like they didn't advocate for themselves. It's not your fault. We as an oncologist should have brought it up to you. But the reality is that we're in is that we need to advocate for ourselves and advocate for our loved ones, unfortunately. There's just a lack of knowledge by providers. There's a bias we talked about, and it just hasn't been an institutional priority. And luckily I see that changing, but just not fast enough. There are good fertility preservation options for most, and the cost of fertility preservation can often be lowered through national programs and asking questions. And please know that you're not alone. I just wanted to highlight the New York Times had a piece this summer specifically about breast cancer patients and females, and just about this conundrum of being diagnosed with cancer and having to make a split-second decision about fertility preservation and being a young adult and having not really thought about it. And I wanted to bring up a couple quotes. I just wanted to read a couple quotes from that piece. So one quote from, again, these are AYA females and talking about fertility preservation. Quote, "I was so overwhelmed and so stressed." Quote, "You're trying to save your own life and someone asks you to think about your future life that hasn't yet been formed." Another quote, "There's a real equity issue here." We talked about that. Another quote, "I felt like no one was on my side or validating that this horrible thing was happening to me." Another quote, "It's not for cancer to decide. It's not for insurance to decide. It's up to us." And again, just the realities of the situation. And I wanted to sort of close. I have two more slides. I just want to close by defining, and you've probably heard it at other talks, about what the NCI defines as a cancer survivor. An individual is considered a cancer survivor from the time of diagnosis through the balance of life. There are many types of survivors, including those living with cancer and those free of cancer. And the definition of cancer survivorship is a state of being including the perspectives, needs, health, and the physical, psychological, social, and economic challenges experienced by people and caregivers after a cancer diagnosis. And this is particularly challenging and germane for our AYAs. So I think particularly in brain tumor patients where sometimes we have cure, sometimes we have remission, but also for some we are living with the diagnosis and living with active cancer. And I just wanted to read this quote from Stuart Scott. For those of you who are ESPN fans or sports fans, you might recognize him. But I really like this quote. "You beat cancer by how you live, why you live, and in the manner in which you live." And I think being able to think about your present, your future self takes a lot of courage, and it's so important. And that's really, I think, how you beat cancer, to put it one way. So with that, all done with the slides, and I'm happy to take any questions that anybody might have.
Hello? Perfect. Awesome. So thank you so much, Dr. Fair. That was a great talk. Okay, so I think we have time for some questions. Are there any questions in the audience immediately?
Thank you so much, Dr. Fair, for that great talk. And I want to thank you especially for highlighting so much of how some of this is on the doctor for not bringing it up, because we hear so much that as patients, we have to be our own advocates, we have to speak up for ourselves. And yes, that's true. But I think as a patient, sometimes we do feel that guilt that, oh, I should have said it, I should have done this. But, it is true that our doctors should be bringing this stuff up to us, and if they're not, then yeah, we have to kind of step up and advocate for ourselves. So I wanted to thank you for saying that, because I think we often kind of beat ourselves up for not saying these things or not properly advocating for ourselves. So thank you for that. And then I do have a couple questions. First would be timing for when you do fertility preservation treatment for those patients who maybe it wasn't brought up when they were newly diagnosed or as they're going through their treatments. Is it still possible for them to undergo fertility preservation after they've undergone treatment? And is there a specific time frame of when that should be done post-treatment, like if they're a year out or 5 years out or even longer than that?
Yeah, thank you for your comments, and yeah, it's a really great question. So I think there are a couple factors to consider. One is, I think, talking with your oncologist about some people. For some people, this matters none, about their prognosis and about how far out from their cancer. As we know, a lot of cancers, not all cancers, have an increased risk of relapse progression within 1, 2, 3 years. For some individuals, that makes a difference where they want to be out a certain amount of time before that is the case. So that's one factor. Another factor for females, and this is true mostly for males too, we generally say about a year from getting chemotherapy is a fair time to start thinking about it. And that is mainly, and of course your body kind of tells you that if you're getting chemotherapy, and a lot of females will experience a lack of period or lack of menses or abnormal menses when they're going through therapy, and really 6 months or even 12 or sometimes 18 months afterwards. So often the body's sort of saying that not ready for that. But what you can do is really, menses should kind of restart by about 18 months after. So that's a good time to get evaluated. And then any time after that is obviously really just a really personal choice. For females, there is more of a quote unquote like a time period. Where males, if they are going to have normal sperm return, that usually happens within a year or two, but there's no time period. If it turns back on, it turns back on, and that will continue out throughout their lives. For females, there is sometimes a truncated reproductive window. And so that is where even if you're done with therapy, there still is now this consideration of like thinking about their future, and there's always a lot of variables for a couple, if you're not in a committed relationship and know that this is the plan. We often don't know when we're going to find a partner, want to build a family, and so that's really an individual choice. I would say that consider getting evaluated. On the female side, it's a combination of blood tests and ultrasounds of the ovaries can really help the REI, that female fertility specialists, kind of give you a sense of your gonadal function or your fertility preservation rate of success. And then, of course, please, on the financial piece, if your insurance does not cover it, or I've had patients who have switched jobs or insurance just to help cover it, but there's lots of financial aid programs. And I will say that there's a lot of REIs or fertility groups on the female side that, and they're usually connected with the cancer center, or the cancer center usually knows of them, like, oh, we usually refer to this center, and then they do discounts for cancer patients, either pre or post. So make sure you look into all of those options. For males, it's usually recommend, if they are curious, usually 12 to 18 months after they're all done with their cancer therapy, assuming they got chemotherapy or brain radiation, they can assess their sperm function by a sperm analysis, which is really simple. It costs about $100, $50 at most places, and really straightforward. And then if there is low sperm function or sperm count or sperm motility, there's blood tests, and then there are male fertility doctors, usually urology trained. So yeah. Did that answer the questions? Okay.
Hi, good afternoon. Thank you very much for the talk. Dr. Fair. My name is Naveed Masood. I'm with Servier Pharmaceuticals, and as you know, we recently had got the approval for vorasidenib, which is Voranigo. There's a reason behind this question, because first of all, this is something that such a sensitive subject, and the fact that you've taken energy and effort to put behind this is so compelling. One of the things we're noticing since we have received approval for Voranigo on August 6th is that a lot of the questions we are getting from patients and from the field and even from physicians is around the fertility concerns. And particularly, as you would know, in our PI, we have not conducted a fertility study. So my question is kind of twofold here. Number one, when patients, and I think you touched on this a little bit earlier around the timing being important, because at time of diagnosis and then at time of prescription, we provide as many types of tools and information that we can between our access services and education. However, we also have starter kits for patients where we give them information not only about the drug, but other support mechanisms we can offer. One of the thoughts that came in my mind during your presentation is, because we're seeing a real big influx of questions around fertility, is this something that as a manufacturer we should consider even from the beginning, or are you kind of saying, hey, listen, the timing might not be right at start of treatment or anything like that? And then the second part of my question is there anything we can do from a manufacturer perspective to kind of do some adjunctive work behind what you're doing?
Yeah, thank you. I'd say for the first, to the first question, I mean, anecdotally, but also the data actually backs this up, and I think there's a few studies that make this exact same point. You are not overburdening patients by talking about their risk for infertility. We feel like that, and we feel like we just gave them really tough news. But the patients will tell you, and there's, again, 3 really good studies that are very clear on this. They want to be told all of their risks, and even if that's a hard thing to hear, they want to hear this and process it and make make decisions about it. So I think from anyone, certainly oncologists, it should be their responsibility. But I think anywhere we can get that message, because it's not getting out to everybody. So whether it's from the pharmaceutical and there's information to say, has your doctor talked to you about your risk for infertility? Have you every place we can put that to make sure that conversation is had, and maybe in 10, 20 years, 100% of AYAs are going to be like, yes, my doctor talked to me about my risk for infertility. I think we can't shout it loud enough from the rooftops, because again, AYAs are telling us that they want to have the conversation, and at diagnosis is the best time, just so they can. But to your second question about studying this, I think it would be great. There's a lot of surrogates, there's a lot of laboratory markers that we can use to evaluate on the male and certainly on the female side, injury to the ovaries and tracking them. And I'm part of a national group that is that right now we have about 20 academic hospitals set up that is going to create this one big database for oncofertility, and that's really where we're going to try to get a lot of information about tracking these patients and about following them through their lives, and about whether they were successful in having live births, if that was something of interest to them, as well as blood markers that often get drawn. So I think we're a little bit behind the ball, but I think we're now realizing how important this is, and I think we have some really good structure to study this going forward, so we can give better information on certain drugs, on certain regimens, and to help that risk prognostication, that risk assessment, because some people would make different choices whether they're high risk or lower risk. So I think we have a lot more to learn, but yes, there are surrogates, blood markers and others that we can use for patients on individual level, and from an individual drug, that I would encourage drug manufacturers and clinical trials, which now this is being built into clinical trials, I'm proud to say, the Children's Oncology Group trials and others, that when you're enrolled on a trial, they will require certain blood markers and certain tests to actually to look at the hormonal function of a patient during and after therapy.
Thanks so much for the talk. I have a question, although I was going to say, as a physician neuro-oncologist, it'd be great to have information to the patient to ask these questions, though the questions can be difficult to answer when there's not data to know what to say. So the two questions you asked were great. I mean, I think it'd be great for patients to feel empowered to bring this question up, as was said, and also to have more data so we know what to say, when that question's brought up. My question, though, was about you had this nice table on the cost, which is a tough piece of this, of course. I'm wondering what that same table looks like in terms of the timeline and time frame. And there are some patients where after diagnosis there is some time to consider this, and we like those situations. There are others where we're really looking to get treatment initiated quickly. How is that cost and time frame, considered as you're thinking about this? What are the routes for a patient to consider to say, okay, I got to do this quickly. This is the best thing to do, for preservation for me, or I have a little bit more time and I'd like to explore that. How does that work?
Yeah, it's really great because the time emphasis is one of the really differentiating factors for a cancer patient and not, in the fact that most fertility preservation, there's months, years that go into just thinking about whether they want to do that, and if insurance doesn't cover it, sometimes it's people switching jobs, as crazy that is, to get a different insurance, or just saving up money. But when you're faced with a diagnosis and you're having to start therapy within weeks or months, you're having to write a check for this cost. So I would say that the steps would be, one, really double checking with insurance companies, and some insurance companies just haven't been asked the question all that, or things are changing. So making sure your insurance company, your insurance does not cover it. Right now in Utah, now Medicaid just came online through a law that we passed like 3 months ago, and so a lot of patients and providers don't realize that they now have fertility preservation coverage. So check your insurance. Then next, if you don't have that, it is see what center you're going to be going to for fertility preservation discussion. Because the cancer center that does refer to a certain group, they often will have a cancer rate that is much lower, usually by half or sometimes like a third, even without using any of these additional programs. So that's the second step. And then the third step would be to look at these individual programs. And again, the Alliance for Fertility Preservation logo here, you can Google them, and that link is right there. They have a list of all of these national groups that are basically created from usually patients or caregivers who face this problem and realize there was a real inequity and a real problem there. So those would be the steps for if you're going before therapy. They're most of the same steps for after therapy. You just have a little bit more time, but there are groups that do help patients regardless of whether it's before cancer or after cancer. A few of these, unfortunately, are intended just before cancer. So I think it's basically the same steps, but having that consult with the fertility preservation specialist. A lot of those clinics, especially the ones that your oncologist will refer you to, that the cancer center knows about, often are very well versed in this as well. So advocating for yourself and looking online and those resources where I pointed you to, but also those clinics usually know about how to defray the costs.
Awesome. So we have one question online. This person is international. They are in Portugal. They were planning on getting pregnant when they found out they had a tumor, astrocytoma grade 2, operated almost 1 year ago. Is it possible to get pregnant in the next few years? What is your experience with older patients?
Well, I'll probably refrain from giving individual advice, but just if you're curious, what was the age that she said?
36.
36, okay. So what I would say is I'd recommend talking to her neuro-oncologist or her neurosurgeon and asking them specifically if they feel like there's any risk, increased risk of recurrence or progression getting pregnant. And this is due to the change in hormones that a female can experience.
She did add on that said that the doctor said that getting pregnant can make the tumor grow again.
Yeah, What I would say there, and actually, there's this really great, from the story from this AYA, the Elephants and Tea, sorry to make you all dizzy by clicking back. There's this really great story from Erin in that where she had a different tumor, not a brain tumor, a neuroendocrine tumor, and she talked about her challenges and frustration in talking to oncologists and them telling her that, like, you are going to make your tumor grow. And what I would just say from that is a few things. One is that often, sometimes oncologists are not always totally up on the latest literature about the risk of pregnancy and tumor progression. So sometimes they just have been taught this, and this is just this is what they say to everybody. So I'd really challenge them to ask their oncologist specifically, are you sure that that is the case? Second of all, I'd really encourage a second opinion to make sure that that is actually, again, true. And then third, I would say this is like a really personal choice. I mean, Erin grapples with this in this magazine and talking about that, and that she got a couple of opinions, and they all said the same thing. But she said, "This is what I want to do with my life," and she has no regrets, and she actually has a healthy child and has had no tumor progression. But it's an individual choice, and I would just say that and unfortunately, as oncologists, we are people that load biases into how we deliver information, for better and for worse. And so I'd say just keep exploring and getting opinions, and know that at the end of the day, it's definitely a personal choice.
Awesome. Do we have any last questions for Dr. Fair in the room?
I'm curious to know if there are any, is there anything proactive that patients can do to help maybe improve their fertility, or at least try to keep the fertility that they have for a longer time? Like, I know I've heard people talk about taking CoQ10 or something like that. Is there anything that you're aware of that could help, that a patient can just do on their own?
With the caveat that I'm not an infertility doctor, but I work with them a lot, and I've heard that question asked, and the answer that I've heard them give is no, being the things that keep your body healthy in general, keep you hormonally healthy. So I have not heard of any supplement or special diet that is particularly healthy for fertility, but just the general recommendation of taking care of your body overall, because your ovaries are organs just like the rest, and so what's good for your body is probably good for ovaries and brain. So yeah, sorry for that answer, but.
Excellent. Thank you so much, Dr. Fair, for this awesome session. We really appreciate you answering all these really important questions for our AYA viewers. And yeah, we'll now dismiss for a short break. So we encourage you also to check out the exhibit booth one last time for the passport contest. The winners will be announced at the close of the event. And then after the break, we're going to reconvene in the Utopia Ballroom at 2:15 for the rest of the program. So virtual attendees, please go back to the agenda and click on the next section to join. Thank you so much, and let's all thank Dr. Fair one last time.
Okay, thanks. Thank you. Appreciate it. Oh, okay, perfect. Okay, great. Well, thank you.
Oh, no, I think you're great. Like, me personally, I think I just need to stop running. I figure remember my paper. So, so you were great. Thank you.
No, thank you.
Hey, Roy Stroud.
Hey, Dr. how are you?
Great. I'm a neuro-oncologist at Wake Forest.
Oh, really?
North Carolina. So this was great. Thank you for giving this talk and topic. It was great.
Oh, thanks so much.